Okay, so we're going to continue our discussion on neurologic disorders. So seizures is the next one we're going to talk about. This is a good video here in the black title, to a good educational video. It's about 4 minutes. I recommend you watching that. Talks a little bit about different types of seizures and also shows some video footage of some individuals that are experiencing seizures. So seizure is a brief disturbance of cerebral function, usually is short, lasts less than 2 minutes, caused by central nervous system dysfunction. Usually the origin is unknown. Epilepsy is probably the most common seizure disorder that we know about or hear more often about, and kind of in a very, very basic way, we can break it up into tonic-clonic or the grand mal seizures, petit mal, which is usually kind of just a sort of a spacing out almost, or maybe just a little bit of twitching, and then status epilepticus, which would be a very big deal, seizure lasting up to half an hour, and then it can repeat, and this individuals they need medical attention, and it can be life-threatening. People who are on anticonvulsant medications, because their seizure disorder is big enough effect on their life that requires medication, so such as the Dilantin. We'll talk more about the gingival hypoplasia that they can see as a side effect of that, so we'll talk more about that in a minute. So the seizures seen in epilepsy are caused by disturbances in electrical activity of the brain, and the seizures in epilepsy may be related to a brain injury, or it could be a genetic factor, it could be some kind of an immune factor, or have something to do with the brain structure or metabolic causes. But overall, all in all, they really don't know the exact cause. There's lots of speculation and studies, but sometimes they have no idea why an individual has epilepsy. So I did want to just quickly mention a patient that I saw at the senior center. She was a younger woman. She was in her mid-30s, I think, and she had severe seizure disorder where she would have multiple seizures in a day even, and maybe not every day, but I mean in a month she would have numerous amounts of seizures. And she told me when she came and saw me at the senior center that she had started a ketogenic diet and had been on it for about 6 months, and she had eliminated her seizures to such a huge degree. I mean, like something like 80% less seizures than she had before from just going on this ketogenic diet. And when I looked into it a little bit more on one of the websites like epilepsy.com or one of these epilepsy web pages that are from like an association or some kind of reputable source, they actually did talk about and touched on studies that are connecting reduction in seizures with ketogenic diet. So I thought that was really interesting. This is from on one of the websites, I can't remember if it was epilepsy.com, but it's a kind of a new classification of seizure types, and I thought this was kind of interesting because it sort of reminds me of how we've newly classified periodontal disease. So some of these phrases I didn't think were going to be necessarily specifically recognizable to us, but basically focal means a specific part of the brain, so it's like one specific area of the brain. So focal onset would be the seizure is coming from just one small part of the brain, whereas generalized refers to the whole brain as being affected. And then motor refers to things like that tonic-clonic seizuring, that we kind of know that phrase a little bit more, or an overall muscle weakness, twitching, something that has to do with motor movement. You know, you think of like movement. And then non-motor would refer to things such as kind of staring spells with or without maybe some brief twitching, but also like emotional sensations and then changes in autonomic function. So a little bit more like sensory and autonomic as opposed to like big motor movements. So those are some to kind of help clarify some of these different motor and non-motor, focal to bilateral tonic-clonic. So bilateral being on both sides, affecting both sides of the brain. So it's where it onsets, where the seizure starts, and then the kind of flow chart of what can happen. And so I just put that in just for information. So seizures, the oral manifestations, nothing specific will manifest orally if somebody has seizures, but it's more secondary results from medication or trauma. So they could have scarring from biting their lips and cheeks and tongue, lacerations from a fall, or if they hit their face while they are having a seizure, fracturing teeth, or a forceful bite. They could crack teeth. And then, of course, gingival enlargement and overgrowth. That's basically caused from the medication, causes an excessive amount of collagen, and that's where the gingival overgrowth comes from. And it can be really interfere with eating or with speech. It can be very disfiguring, and so we want to help our patients with that. So our dental hygiene considerations, mostly we just want to try and prevent a seizure from happening in our dental chair. So we want to ask questions. If they mark on their medical history that they have epilepsy, then we want to ask them some follow-up questions. Is this a good day to have dental care? Have you had any feelings or under stress, or are you fatigued, or what usually triggers a seizure? When was the last time you had a seizure? How often do you have seizures? So we want to think about all of these questions to help us determine if it's really a good day for them to be at the dentist. Nitrous oxide is contraindicated. Nitrous oxide and oxygen have been contraindicated for individuals with epilepsy. And because fatigue can induce a seizure, we want to try and stick to shorter morning appointments when they're feeling refreshed and not tired. And we just want to management of seizures if they do occur. So we mostly just want to prevent injury. We want to move away anything that the patient could hurt themselves. We want to help them maintain their airway and ventilation, and activate EMS if that's necessary. And then base frequency on severity of gingival hypoplasia and enlargement. So the frequency of their visits will basically come down to how is their oral health in general? Like, is their gingival hyperplasia just really bad and we need to see them more often to help them minimize that and help reduce it and maintain oral health? Are they building up plaque biofilm because they're, just not doing a good job, and so we have to talk to them about the benefits of reducing the bacteria and the effects that has on the hypoplasia. So we're just going to base it on their individual needs and their risk factors and what we see in their mouth when we do our assessments. So oral hygiene habits make a huge difference in drug-induced gingival hyperplasia, and it's really important that our patients know this. If they don't realize that they can actually affect the severity by taking really good care of their teeth, that's our responsibility to help them understand it. And so we want to stress good OHI, frequent maintenance visits, if necessary, depending on how well they're maintaining their oral health. And clients who do not comply with flossing may prefer a water pick, oral irrigator, soft picks, or tepe brushes, or some kind of interdental brush. Cocoa floss is great, though. I wrote, cocoa floss is great though and makes you want to floss. So it is, sometimes it's something just kind of kitschy and fun to make someone want to do something. It's like, if you like your floss better, maybe you'll actually use it. So, but anything that makes somebody want to, use some kind of an oral hygiene aid is really basically what we want to choose for them or guide them toward. So peripheral neuropathies is the next one. So peripheral neuropathies are conditions that develop as a result of damage to the peripheral nervous system. they're due to damage of the axons or the myelin sheath around the axon. It distorts the signals between the central nervous system and the rest of the body. So there's different kinds of damage. There could be motor nerve damage, which would then we would see muscle weakness, twitching, atrophy, decreased reflexes. And then there's sensory nerve damage, which could manifest as numbness and tingling, paresthesia, pins and needle feelings, an inability to feel pain, sensory loss. It may also result in temperature sensation, so feeling cold or like a burning sensation, uncoordinated movements or sensation of imbalance, particularly with the eyes closed. And then there's sensory nerve damage that may cause pain, and the pain is very hard to treat. It can feel like a burning, jabbing, tight band or a pressure. Then there's the pins and needles and the instability with balance and the weakness. We kind of already touched on those. So peripheral neuropathies are associated with alcoholism, diabetes, and where was it? It was like respiratory. Specific neuropathies conditions are associated with alcoholism, varying degrees on the type of nerve damage. But there was I thought it said respiratory. I must be thinking. Oh, here it is. Okay. So individuals with diabetes or upper respiratory ailments are affected disproportionately. So we know diabetes because of the damage to the little microvascular system in the nervous system, the peripheral nerve damage, but also upper respiratory ailments, which I thought that was interesting. Oh, I'm sorry, that's for Bell's palsy. Okay. So then in general, so that's peripheral neuropathies does include diabetes, but also alcoholism, HIV, and infection. So one type of peripheral neuropathies is Bell's palsy, and that's the most common facial paralysis. So the facial nerve or the cranial nerve 7 becomes inflamed and then compressed, and then communication is interrupted. And this can occur at any age, but it's most common between like 15 and before the age of 60. You usually don't see it younger than 15 or older than 60. And so this is where individuals with diabetes or upper respiratory ailments are disproportionately affected by Bell's palsy. And viral causes are actually suspected. And it can be iatrogenically caused from oral surgery or local anesthetic injection as well. So symptoms and treatment, individuals think they've had a stroke. They may wake up and half their face is just slumped. Pain behind the ear, drooling, altered taste, tearing of the eye. They can't really close their eye all the way, so it can kind of dry out or excessively tear. Steroids and antiviral agents, eye lubricants, sometimes surgery to decompress that area or galvanic stimulation. Most people, though, recover fully without much interference at all. And then oral manifestations, while the patient is experiencing the paralysis, they're going to have difficulty chewing, difficulty cleaning on the side that's affected and clearing food from the affected side. They could bite their cheek or their lip or their tongue. They could have dry mouth, glossitis or candidiasis. If they're kind of drooling in the corners of their mouth, that might encourage candida growth. So those things, depending on what symptoms they're having, will depend on what kind of medications or that we might recommend to them. Protective eyewear during a dental appointment, but also in general, just while they're having the paralysis, they may need to wear either like a patch over their eye or glasses to help prevent, because their eye isn't going to close, so they're not going to blink, they're not going to have that protective reflex. Counseling for self-cleaning difficulties. They're not going to feel the toothbrush or the floss as well on that side, so they might not clean that well on the side that's affected. And then adapt for impaired musculature too. They just have to be aware of those sort of weaknesses while they are affected by it. So may not brush as well due to the numbness, establish a brushing pattern, and they need to kind of watch what they're doing in the mirror, rinse water after eating, an oral irrigator, like a water pick. So trigeminal neuralgia, mononeuropathy, trigeminal nerve, cranial nerve 5, severe facial pain. This is very debilitating. It predominantly affects females over the age of 40, and it's observed quite frequently in individuals with MS, and we know women are disproportionately affected by MS. Family history with vascular abnormalities is a possible cause, but it's a nerve compression. It could possibly be a benign tumor, but that sometimes has nothing to do with it at all. So something just is compressing the nerve, or a vascular malformation. So the blood vessel might be pushing on the nerve or rubbing on the nerve, and eventually gets through the myelin sheath and causes this severe pain. So it's a neuropathy of the trigeminal nerve 5, which we said. And so sometimes the drug therapy could be anticonvulsants or tricyclic antidepressants. Opioids and pain medications do not seem to help the pain at all, which is, pretty awful. Here's a picture that shows a type of surgery that a patient may have. There's these sponges that they put to protect the nerve, because here's the artery that may be impinging or putting pressure on the trigeminal nerve, and causing the severe pain. Oral manifestations, oral ulcerations or xerostomia may be from the medication, especially if it's a antidepressant. And then avoidance due to fear of triggering pain. So wind, like the wind blowing, can trigger pain. Manipulating their mouth for eating or oral care can trigger the pain. So patients can be terrified to go to the dentist, to think of having this pain come. So biofilm related diseases could be very possible, because they may avoid brushing and flossing and doing anything that they feel could trigger the pain. So we have to have empathy if they know that they have trigeminal neuralgia, if they've been diagnosed. We have to be very understanding and not be judgmental and say, your teeth are going to fall out if you don't do something. This is not their choice. So we have to work with them and understand their narrative and see what we can do, come to a place where we can help them with their oral hygiene. And hopefully the symptoms will become under control, and they'll either have surgery or something. The symptoms also come in waves. They can have episodes that last for months, and then they might have nothing for years. So a definitive diagnosis could take time and be very frustrating. It's well established that distinguishing trigeminal neuralgia from odontogenic pain is really challenging, and there have been numerous studies that demonstrate patients having had teeth extracted and root canals and expensive oral dental care just to find out that they had trigeminal neuralgia, and they didn't have anything wrong with their teeth. So it can be very, very frustrating. Local anesthetic may relieve pain in the chair, and also a patient laying in a fully supine laid back position may relieve pressure. Short appointments, referral to, surgeon, physician to help with diagnosis, individualized self-care, talk to the client about specific difficulties. And okay, I'm going to stop there, and then I think we'll do the last one in just a minute.